All right, I'm going to get started here. Thanks everyone for joining. I'm going to just start. I'm going to mute everyone but myself so that there's not a lot of background noise. But there's also a chat function at the bottom right corner if you need to send a message or say anything. And then I'll unmute everyone at the end and we can do some question and answering. So my name's Tony Spadero. I'm part of the education and base building team at Snap. Thanks for coming and attending our first of what we're planning a 4-part webinar series. It's something we've been wanting to do for a really long time. So I hope you all find it enjoyable, and we're recording this and we're hoping that in the future this will be a good resource for new Snap chapters that are forming around the country in case they need help giving a talk such as this. So I wanted to start off by explaining a little bit about what insurance is generally. So I think you can think of insurance as a common fund that we use to pay for healthcare expenses when we're sick. You can think of it like this pot of gold. Now what goes into that pot? It's the premiums people pay every month to a private health insurance company, or it could be something that's paid into through taxes like Medicaid, Medicare, and Medicaid. Now, what comes out of this pot? It's physician reimbursement. It's how you guys are going to get paid in the future. It's also what pays for drugs, medical devices, hospital stays, that sort of thing. And what defines who is putting in and who is taking out of the pot? That's defined by who is in your risk pool, who is in that insurance plan. This could vary. It could be everyone who buys insurance through the private insurance company you have a plan at. It could be everyone in your state, or it could be everyone maybe in the country in the case of something like Medicare. There's a lot of ways of tweaking what comes in and out of this pot, because an absolute disaster would be if people needed to get money to pay for their health care and there wasn't any money in this pot. One mechanism for tweaking the inputs and outputs and making sure this is a steady flow is something called copays and deductibles. Copays is a fixed amount that someone pays every time they go to the doctor's office, or maybe for prescription drugs. Deductibles work in a sort of similar fashion, in that it's an amount that you as an individual pay up to until, and any expenses after that amount, the insurance company picks up the rest. This isn't going into the pool that's commonly the common fund that's taking care of everyone. Rather, it's going directly towards paying for your individual health care. But insurance companies and insurers are interested in this because it affects behavior around the risk pool and around this pot of money by encouraging people to take less out of it. It's something that healthcare economists refer to as preventing moral hazard, or having individuals have skin in the game, as if there wasn't enough skin in the game in your own health. Ultimately, for private insurance companies, they need some money left over in the pot in order to secure a profit so that their CEOs can get paid and they can share that profit with shareholders. And I think most healthcare reform seeks to make tweaks at these various inputs and outputs to make sure the health insurance system is running in a steady fashion, so they can change taxes to encourage money to go into the pot. They can affect maybe employers' behaviors by giving them tax deductions if they buy health insurance for their employees, encouraging people to put money into the pot. They can change reimbursements, so they can either negotiate with one group of physicians over another and pay them slightly different than another to affect what's coming out of the pot. They could change the style in which they reimburse, either as a fee for service where they pay for each individual service provided by the doctor, or they could pay the doctor a lump sum and have that lump sum go towards maybe the yearly expenses for a particular person that buys that health insurance plan. And then there's also lots of regulation out there about what kind of behaviors, what level of profit a health insurance company can have. They can regulate the risk pools either through something like an individual mandate, where they require people to buy into the risk pool, or they could create exclusions or get rid of exclusions for people with pre-existing conditions. It's obviously like a very simplified view of what insurance does, but I think it's helpful to think about how these various inputs and outputs function and how they're regulated, and kind of what that means for health care reform. The healthcare reform that we're interested in is single payer. So you've probably heard a lot of different terms for this: single payer, Medicare for all, national health insurance. What's the difference? I'm here to tell you that they all mean essentially this exact same thing. Medicare for all polls slightly better, so I tend to try to use it in talks like this, but really I think you could use them interchangeably. So while in your schooling you're probably focused on what happens between patients and providers, this talk is mainly thinking about what happens in between the two, and that is cash exchange. Right now, there are many payers in our health insurance system. There's multiple payers. There's the federal government, state governments, private health insurance companies, and those all contribute to allow individuals to purchase healthcare. Now, what we're proposing is that there would be one single payer, the federal government, that provides health insurance for everyone, that mediates this entire transaction. And that's why sometimes it's known as national health insurance. But because most single payer advocates also want to build on the existing federal framework, they often we will refer to it as Medicare for all, to reflect that what we want is to build on the current system we have, and expand Medicare to make it available for everyone. And I would say Physicians for a National Health Plan also adds improve it for everyone, so it should be an improved Medicare for all. So I think when we think about how we want to talk about single payer, there's a lot of different frameworks for how we could explain our support for Medicare for all. For instance, I think in this talk, I'm going to focus more on the first two of these frameworks, the policy framework and the human rights perspective. I think the policy framework is really good at convincing other healthcare providers, other physicians, that a Medicare for all system can work. I think PNHP does really excellent presentations where they lay out all the data that shows that we can cover everyone for less money than we spend now. I think also the human rights perspective is compelling for a lot of people, and a lot of people are convinced that providing healthcare for everyone is the moral thing to do, and that Medicare for all is the way that we provide healthcare for everyone. Some of our future webinars, Dr. Ed Weisbart next week is going to talk about the conservative case for single payer, and I think that often invokes the business perspective that many companies would save money if they didn't have to provide their employees insurance. And then in 2 weeks, Dorothy's going to, I think, talk about the racial justice perspective, that a single payer system or Medicare for all can help us start to deal with some of the racial inequities in our healthcare system. I think another important framework for talking about Medicare for all is our patient's perspective. I know probably not everyone in this webinar has seen patients yet, but for those of you who have, or once you start seeing patients, those stories are really powerful and I think personally motivating. But I think when you talk with politicians and people who aren't familiar with the inner workings of the healthcare system, our patients' stories can sometimes be the most powerful thing to convincing someone they should support Medicare for all. So that being said, I think single payer can still be very challenging to explain, and you can often get wrapped up in the details. I'm going to try to explain single payer or Medicare for all in the way that makes sense, and hopefully will help you talk to your classmates and talk to other healthcare professionals and convince them this is something that's doable and worth fighting for. So if you come at it from a human rights perspective, I want to think, what does it mean to say that healthcare is a human right? We can say things like everyone should be able to get insurance from cradle to grave and have all their healthcare paid for. But it's also, I think, important to say that we want an equitable and just system, one that's paid through progressive taxation, so it's not the sickest people and the most vulnerable people paying more, but it's spread out in a way so that the rich are paying more. And I think we also want to create healthcare as a right and not a commodity. So we want to get rid of the cost sharing, the copays, the deductibles, the things that are barriers to care for low income individuals. Ultimately, I think Medicare for All is the system that can achieve that, and it has a number of advantages in that goal of healthcare as a right. So I think first and foremost, it puts everyone in the same boat, the same risk pool, which is advantageous from an insurance standpoint. But it also creates a system that rich and poor alike are invested in. So the most politically resourced among us, the richest people, have the same incentive of having a well-functioning Medicare system as the poorest among us. And I think that can help ensure that it's a well-funded system. It means that healthcare will no longer be tied to the workforce, which I think has lots of benefits for employers and employees. But I think it also has the advantage of transforming healthcare as something that's seen as something you earn through work and something that you have a right to by being a human. It also creates all providers will be a network, so that gives freedom of choice for patients. And then I think one of the more powerful things about Medicare for All is that it will be in the interest of the government to promote health. Right now, under our private health insurance system, most private health insurers know that you will not be with them your whole life, that you transition jobs or insurance plans many times throughout your life, and then ultimately you're the government's responsibility. But under a Medicare for All system, your healthcare expenditures are the government's healthcare expenditures throughout your whole life, and the only way they can reduce that is by making you healthier. And so you could imagine a world where it's determined that access to healthy food lowers healthcare costs. So food becomes seen as part of healthcare, or that access to housing lowers healthcare costs. And so housing is seen as healthcare. And the advantage of Medicare for All is also that the government is in a position where it can actually impact food access through programs like SNAP, or housing through programs like the federal housing programs we have. So I'm sure some of you are probably, if you have a healthcare economics class at your school, they often use this framework, and I wanted to sort of draw upon it to explain Medicare for All. This is the so-called triple aim of good healthcare systems: improving access to care, minimizing cost, and improving quality of care. Some healthcare economists are cynical and say that maybe at best you can accomplish two. I think Medicare for All activists are optimists and think we can accomplish all three. But I think it's important because most healthcare reform sort of happens in light of these three aims. So before we get to Medicare for All, I wanted to talk a little bit about the ACA that some of you are probably at least passingly familiar with. So there's three main pillars of the ACA. It wants to regulate insurance companies, prevent them from denying coverage to people with pre-existing conditions. It has a number of regulations on what they can and can't do. It wants to have an individual mandate, although that has recently been repealed. But the goal of that was to have everyone go buy insurance to increase the risk pool. It also wanted to subsidize insurance either through Medicaid or through subsidies that allowed low-income individuals to get access to care. Now, ultimately, those three things are meant to increase access, and that's probably maybe 100 pages out of the 900 some pages that the ACA is. The rest of the document deals with sort of patchwork fixes to accomplish some of the other things, like minimize cost and improve quality of care. There are some things like electronic medical records that were thought they would improve quality of care. So there's a lot of stuff about that in the ACA. There's alternative payment models like accountable care organizations that are meant to use alternative payment structures to physicians to encourage high quality, lower cost spending. I think it's questionable how successful some of these have been. But just to know that there's a lot of stuff like this in the ACA. Some of it's good, some of it's not as good, some of it's hard to even know how to rate it. But I would say overall, the message I want to convey is that the ACA ultimately lays upon patchwork fixes to the system we already had, and ultimately it doesn't fix some of the underlying problems in our system. And I think being a patchwork system, it has the downside of being confusing and hard to explain to people. And so you see things like this where 1/3 don't know Obamacare and ACA are the same thing. I think this can make a program politically vulnerable. And I think that's a good lesson for activists such as ourselves to keep in mind in how we talk about these issues and why we're framing what we want to do as different. So keeping that triple aims in mind, I want to talk about how Medicare for All is going to work. So first, I want to talk about cost. Now, there's a lot of ways that Medicare for All is going to reduce costs. The two main ones I want to hammer home is that it's going to reduce administrative overhead, and it's going to allow us to negotiate better drug prices, and that will save us a lot of money. So right now, as you may or may not know, the United States has the most expensive healthcare system in the world. This is a little old data, I think now we spend more than $10,000 per capita per year, but we're not really getting our bang for our buck. We're number 25 in life expectancy. So I think that sort of begs the question, where is all this money we're spending on healthcare going if it's not improving our life expectancy? So some of this huge healthcare expense is that not all our healthcare dollars are spent on the actual delivery of healthcare. Some of it goes towards things like medical overhead, administration, insurance profits. And so if you can compare the United States to Canada, which does have a single payer system, they also call it Medicare, is that our overhead administrative costs are around 31% so that's 31 cents of every dollar compared to Canada, where it's around 16. What does that translate to? If you paid a $1,300 a month premium, that means $400 of that is not going towards the delivery of healthcare. Now, some of this has to do with the way that insurance companies are structured. Private insurance companies have overhead in the range of around 17. Because they're smaller, it requires more people to really determine whether or not any individual, what their healthcare expenses are going to be and what their premium should be. And it's a very complicated, and how they're going to deal with hospitals and how they're going to negotiate with some physicians and not others. So ultimately that leads to very high overhead. If you compare that to Medicare, which has an overhead around like 2 or 3%, there's a lot of money we're spending that's not actually doing us much good. I think you can see some of this reflected in the growth of physicians compared to billers. So one anecdote I heard was that there's a hospital system in North Carolina where there's over 900 billers, and there's not even 900 beds in that healthcare system. Yet there's certainly not 900 physicians or 900 nurses to take care of each individual patient. Some of this is reflected that each insurance company has its own paperwork, its own requirements, and that creates a lot of administrative burden on the healthcare provider end, to figure out how the things get billed and paid for, that sort of thing. There's also the issue of CEO salary. I think this sort of speaks for itself, that these people are making over $10 million and they're not seeing a single patient, which obviously we would eliminate this expense in the Medicare for All system. If you look at what we're paying for prescription drug prices, that's another way that Medicare for All activists plan on saving a lot of money. So if you compare countries with more, where their insurance plans have more public drug coverage, they tend to pay less drug prices than we do in the United States. Ultimately, private insurance companies don't have the negotiating power of a single payer system in negotiating lower drug prices, and Medicare itself is prevented from negotiating drug prices, and so that's what leads to high drug costs. And so you can see for some wholesale drug prices in the United States that they're hundreds of dollars, and if you compare that to Canada, which does have a single payer system, it's much less, and this would be a source of savings if we switch to a Medicare for All system. Ultimately, pharma is also not our patients' friends, and they're profiteering off of people's illnesses. So you could argue that the increasing healthcare costs as a percentage of our GDP is a reflection of the increasing complexity of care. We have things like MRIs now that are used more often. All sorts of advancements in technology means we're going to spend more on healthcare. But I think if you compare our system to Canada, is that Canada, Medicare for All system in Canada has been able to negotiate lower prices, and that ultimately is able to curb some of the rising costs in healthcare. So ultimately, I think switching to a Medicare for All system will allow us to curb the sort of out of control growth in healthcare. There's also the issue of quality. And again, there's a lot of ways that Medicare for All is going to improve quality of care. Two things that I want to emphasize is that it's going to get rid of what I call junk plans, and it's going to end the class-based rationing that we have under our current system. So a lot of people, medical bankruptcies are one of the leading causes of bankruptcy. What you may not know is that most people with medical bankruptcies have insurance at the onset of their illness. So I think this sort of begs the question of what their insurance is doing if it's not preventing financial catastrophe. Ultimately, some of this is due to the high deductible system we have. So a majority of people now have deductibles greater than $1,000. Some people have plans where the deductibles are $3,000, $6,000, and most people don't have enough money in their bank account to cover their deductible. So most low-income individuals don't have $1,000 in the bank, and so that makes their insurance essentially useless because they're never going to be able to pay their deductibles to get the insurance to kick in for any healthcare expenses after. What does this lead to? This leads to worse care. So this chart shows that uninsured individuals and underinsured people who have coverage but have cost sharing that they're worried about tend to delay seeking care for things as serious as a heart attack. This also, I think, is reflected in who sees what kind of patients. So right now, the sort of fractured system we have where richer individuals have private insurance and poorer individuals have public insurance is that many specialists won't see kids with public insurance. Ultimately, some of that is due to not to any bias of their own necessarily, but because it reimburses lower. Ultimately, we'd want to change that structure so that disparity is eliminated. And I think if you look in Canada, you don't see the same disparity between the poorest and the richest in access in surgical waits, for example. Even for Americans with above average incomes, they tend to get worse care. They tend to delay seeking care due to concerns about costs or getting treatments. I think you'll probably find that many of your patients, the financial consequences of their hospital visit is in the forefront of their mind, which shouldn't be the case. I think probably the thing that everyone is familiar with Medicare for All, how it's going to improve access, it's going to have everyone in, nobody out. So even undocumented people living in this country are going to get care. The poorest of us are going to get care. Everyone is going to have coverage. So this graph is already out of date, but under the ACA, there is projected to still remain 28 million uninsured individuals despite all the efforts it had to improve coverage. Now, because of the GOP tax bill, the number of uninsured in this country is expected to go up to 41 million. With a Medicare for All system, that number would be 0. Ultimately, what does this lead to? People without insurance have a higher rate of mortality. So this, in effect, this is with the old numbers. This number is going to go up now because of the GOP tax bill. But even under the ACA, there were still 29,000 Americans that were dying every year because of the excess mortality from being uninsured. It's not that people willingly or go without insurance. This graph shows that health insurance is becoming increasingly unaffordable, taking up an ever larger percentage of median family income. And so now most people just can't afford insurance at all. Another way that Medicare for All is going to improve access and deal with some of the deficiencies of the ACA is that although everyone loves the fact that the ACA prevented insurance companies from denying coverage to people with pre-existing conditions, insurance companies found a way around that with something called formulary design. Formulary design basically means they set different drugs at different tiers for how much they'll pay for the drug. So for tier 1 drugs, they pay pretty much the whole cost. For tier 5 drugs, they might expect the individual to pay for the full price of the drug. And effectively, they can use this formulary to exclude people with pre-existing conditions. This example shows that in the Massachusetts plan, there were no plans available that would provide tier 1 coverage for HIV drugs, effectively making these insurance plans useless for people with HIV. So that is sort of my general overlay of how a single payer system is going to improve access, improve quality, and reduce costs. Now, everyone on this conference might be on board with that, but you might wonder if that's broadly popular. I want to tell you that it is. This is actually kind of an older poll taken before Bernie Sanders' bill, but still showed that the majority of individuals favored an expanded universal Medicare for all. If you look specifically at Democrats, that number is around in the 80s, and you could say that's good, but that doesn't really reflect the entire country. Well, if you step outside of your progressive bubble, even a majority of independents at 60% support Medicare for all. And I don't think this is a bad amount. Like 3 out of 10 Republicans, about 30%, rate expanded universal Medicare for all favorably. So there's still a lot of work to do out there about these sorts of things, but there's still broad support out in the public for Medicare for all. Now, you might find yourself sort of lonely in the hospital wards and say that you might be the only single payer activist out there. I want to tell you that you're not, that actually there's broad physician support for a national health program. There's some specialty variation, but I think if you look across specialties, the average is around 59% of physicians support Medicare for all. So I want to talk about 2 plans that are out there. Though there's one bill in the House, HR 676, It is about 30 pages, so you could probably skim through it in an hour or two if you really wanted to. But it's going to do a lot of the things that I just talked about. It's going to streamline payment to providers, and that it sort of saving from administrative waste, and also allowing bargaining of prescription drug prices. Is going to save a lot of money. It's going to use that money to increase the number of people that are insured, and it's going to get rid of the cost sharing, the copays, the deductibles to prevent people from seeing their doctors. So right now, the last time I checked, maybe I need to update this, but at least there are 120 co-sponsors in the House. That translates to a majority of Democrats in the House. So it's going to do the things that we talked about, and it's going to use that, and it's going to, through the saving mechanisms, it's going to implement a better health insurance system. It's sort of light on the details of how it's going to be implemented, which sort of takes me to the other bill out there about Medicare for All, Bernie Sanders' bill in the Senate. This bill is about 90 pages, which I think is also a doable read in about 2 hours. And I think this is, a much more exhaustive plan of what we're really talking about here. So just to lay it out, it's going to cover all inpatient, outpatient, emergency room care. It doesn't cover all long-term treatment, which is something that PNHP has pointed out it should. It allows for Medicare to negotiate drug prices. It eliminates copays and deductibles for pretty much everything. It leaves some copays in place when there is a brand name drugs, when there is a generic option, to encourage people to use the generic instead of the brand name, as a way of reducing overall pharmaceutical spending. And then it also, I think, important to note is that it prohibits the sale of duplicative insurance. That means that it gets rid of the private insurance market. How is this going to be implemented? There's a 4-year implementation stage where it gradually reduces the age of Medicare eligibility from 65 to 55 to 45, and so on. It makes some immediate improvements to the Medicare system as we see it now. It's going to add dental, vision, hearing. It's going to limit the out-of-pocket expenses. It's going to create a public option for people to buy in until it's fully implemented. And I think we can talk about this more if people are interested in it, but I think it makes a number of recommendations for how to improve quality and control costs. It creates an Office of Primary Care, for example. It also creates it gives Health and Human Services a number of options to ensure that physicians abide to evidence-based guidelines, like the Choosing Wisely guidelines you might have heard of, in efforts to improve quality and curb costs. So I think that's certainly probably before the bill would ever be passed. I think it's something to look at, and how that's going to also act in those areas of healthcare reform, but it certainly doesn't leave it untouched. So a lot of critics have said that Bernie Sanders hasn't proposed how this is going to be funded. That's not true. He released a white page in conjunction with the Senate bill that sort of explains some funding options for it. There's a couple different ones. I think for me, it's easy to understand the 7.5% income-based premium on employers. So employers now spend money on providing health insurance for their employees. For instance, General Motors in 2009 spent more money providing its employees health insurance than it did on building cars. So it's a huge business expense. It would get rid of that expense and instead tax those businesses, which would raise the money to pay for this system. And actually, it would save businesses money. But that's just one way that it's been proposed being paid for. So under this if we do pass, at least this was under HR 676, maybe this would also be the case under Bernie Sanders' bill, is that most Americans, 95%, will pay less than they currently do. Right now, Americans pay taxes and premiums towards health insurance. This would collapse that into just taxes, and that amount of taxes would be less than what Americans currently spend now. So that's most of my talk. I wanted to plug some upcoming events. There's the SNAP Summit in New Orleans on March 3rd. SNAP does, or PNHP does offer travel scholarships. The deadline for the travel scholarship is the 21st. Be sure to check it out. There's a lot of really good talks there. It's a lot of fun. We also have our upcoming webinars next week. We're going to have Dr. Ed Weisbart give the conservative case for single payer. And then in the following week, we're going to have Dorothy Charles talk about the intersection of racial justice and single payer. And then on the last week, we're going to have Anand talk about effective single payer advocacy. So be sure to check those out. Tell your friends about them, because I think they're going to be awesome. So I saw a few questions that were proposed sort of via the Google form. So I wanted to just talk about some of these quickly. This one is, how would physician compensation change in a single payer system? How are the decisions on how to allocate every healthcare dollar made in the single payer system? As in the decision of what gets covered and what doesn't. The first thing I wanted to say is that if you compare Canadian salaries to physician salaries, that they're pretty similar. And Canadian physicians certainly don't seem to be suffering under a single payer system. But I think in terms of decisions on healthcare dollars are going to be spent, is I think some of those powers go to departments like Health and Human Services that can sort of create a similar like fee schedule that would determine how much it reimburses physicians for things. If it's like a cardiac cath or a primary care office visit, like it'll determine reimbursement rates for those sorts of things. Is how it will happen. Obviously, I think there'd probably be input by physician groups lobbying, similar to there is now. But I think that was a good question. Some of these other ones I think are a little complicated, but we can certainly talk about that. I wanted to take the chance to unmute everyone so that we can all talk about it. So, hello?
Yeah.
Does anyone have any questions they'd like to ask or see one of these answered? So I think this last question about large private for-profit hospital systems, how would they adjust to a single payer system, or would they have to? So I know PNHP has taken the position that the Medicare for All bill should basically ban for-profit hospital systems. I don't think Bernie Sanders' bill has done that, but I think that they would still be allowed to exist, and they would sort of have to figure out how they could still make a profit within, I guess, the fee schedule the Medicare for All system would employ. I would add that Bernie Sanders' bill does allow for physicians to not sort of participate in the Medicare for All system, or hospital systems to not participate in it. So I guess it is feasible, although it would require enough people that would opt out of the system to actually, go to these hospitals. So I'm not really sure exactly if there would be any sort of for-profit hospital systems if we did switch to Medicare for All. This other question, how will we transition from a for-profit private insurance healthcare system to single payer, and what will happen to all the people employed by insurance companies? So Bernie Sanders' bill does include a part where it would use some of the money saved by the Medicare for All system to retrain people whose jobs were basically displaced from Medicare for All. I know, to put it in the context, I think there's about like 20 million people that get laid off, fired, or quit their jobs every month, and that the whole insurance, the number of people that would be displaced by a Medicare for All system is like, I forget exactly the number, but it's like 2 or 3 million. So it's still like a fraction of the number of people that are required to find new jobs like every month, which I don't think completely, is an easy answer for this question. Which is why I think Bernie Sanders' bill also has the part about funding for retraining. I think a lot of these questions around provider reimbursement are interesting. I think a lot of provider time today is being spent on documenting stuff and billing stuff. And so I think they found, and I think generally in like Canada, physicians spend less time doing that sort of administrative stuff. And so they can see more patients per day. And I think that is how compensation ends up being the same, is that although, let's say, like reimbursement for an office visit is slightly less under a Medicare for All system, is that you can see more physicians per day because you are not spending so much time on the phone or in front of a computer, and so that your compensation ends up being about the same. And I think that's why in the chart I showed about Canadian physician compensation, that it was similar to American levels. I got a question about infographics that you recommend for the local chapters to share on their media pages, or quick info pages we can share with the schools on our campus. So I would say, like most of my resources, I relied on Physicians for a National Health Program's website. They have, if you go on their website, in the left-hand column, there's like a bunch of different tabs, and one is slideshows, and there's a password-protected slideshows, but the password is just the last name of the president of PNHP. And you can have access to all the information in these presentations. I think Kaiser Family Foundation, if you just go on their website, they do a lot of healthcare blogging sort of stuff. And if you just typed in single payer, they have a lot of good infographics about that. I think there's, on the SNAP blog, I'm pretty sure there's also resources on that too. You could also check out like the PNHP's Facebook or Twitter pages, because I think they also post about different studies that came out, different charts that sort of become popular and viral, and explaining the number of people that are going to become uninsured because of like the tax plan. Any other questions?
Yeah, I had a quick one. So I know, like typically, like in public opinion, the discussion of like wait times is often brought up. I was actually just in Ireland, and I'm not sure if everyone's aware of like what the NHS crisis is over in the UK right now, as far as like bed situations. Do you think that that will affect our advocacy efforts concerning the Bernie bill? Do you think that'll come up? And do we see that as like a real thing that can happen?
So that's a good question. I think that is something that will be brought up in the course of our advocacy. And I think there's a couple of different ways you could respond to that. So I think part of the issue with the National Health Service in Great Britain and Ireland is that it's suffered a lot of attacks from conservative governments and they've cut fundings for it. And so that's really um, created a crisis where, like during flu season, um, there there becomes these like really long wait times. Um, and I guess there's not necessarily a guarantee that if we go on the Medicare for all system, that they couldn't come under attack, and the sort of cuts the funding could create wait times. But I think it's important to create that that doesn't necessarily mean that would happen. That hasn't happened in every single payer system. And I think that's also why, even if Bernie Sanders' bill were to pass, we'd have to continue fighting for a well funded and well maintained system. I think the question of wait time is certainly an interesting one because I think there is wait times and rationing in American healthcare. It just most often falls on low income individuals where people with Medicaid have to wait months before they can get a specialist appointment. And I think this, I guess, is also a good point that I was reading when about the ACA when it was being passed, is people were concerned that the ACA, by increasing coverage, would create all these wait times. Um, and that really hasn't been borne out to be true. Um, they
What do you think that comes down to, like, you know what I mean, appropriate and accurate triaging? Because it seemed that like the headlines over there while I was over there were that, they don't have all these beds and there's physicians speaking out and, causing all this concern. However, they were interviewing patients and, people are saying like, oh, I got my heart valve replacement, no problem. Like I showed up, I was in acute distress and they fixed it. So it's not like they're necessarily like turning people away, you know what I mean?
Yeah, no, I think that's true. Yeah, I think that's really like I think it's tough because you want to deal with the question, but you also don't want to, I think, propagate false rumors. Like I think a lot of people point to wait times in Canada, and they just really aren't significantly different than they are in America. And for like probably like a primary care visit, it's probably a better, like the wait times are probably better in Canada.
Yeah.
And I think with things like the National Health Service, I think they do try to triage and see the emergent stuff first to make sure that no one's like turned away when they really need it. Um, but I do think some of it comes down to like having to fight for the system even after you won the reform to make sure that the funding's still there, so be well maintained.
Yeah, that's a good point.
I see a question about will either bill cover addiction medications or treatments or expanding. Um, it is so it will cover the addiction medications and treatments. Um, it won't cover like long term care for like long term, or at least Bernie's bill doesn't cover long term care um, for like skilled nursing facilities for like weeks, but it does leave some like Medicaid type coverage for low income individuals to get a senior skilled nursing facilities. But I think for addiction treatment, it covers most addiction treatment. And then I think someone here pointed out that Medicare for All is a little different than what they have in the UK. And in the UK, it's both public insurance and public hospitals and healthcare providers. And the government, in the UK, um, the hospitals and doctors and their government employees, whereas in Canada, it's just the health insurance system that is provided by the government, and the doctors are still like kind of they work for hospitals and the hospitals are nonprofits or for profit or whatever.
That's a good point.
All right, well, if there's not any other questions, I want to thank everyone for attending and encourage them to, keep attending the future webinars. And if you have any feedback for me or Kale is also on this conference call. He's one of the other education and base building co-chairs. If you have any feedback for how to do these webinars or how to organize them, you can email us. But thanks for attending, everyone.